thanks, Mike, for the kind introduction. And as Mike said, I'm going to be talking about the standard of care today for chronic hepatitis C, and then some of the future treatment options for hepatitis C. Before I jump in, though, I wanted to lay out one of my goals, and that's to try to bring home all the other lectures that we've had by Dr. Lemon, by Miriam Alter, by Mike, and by Steve Polyak, and try to incorporate some of the things that they talked about and how that bears on the treatment and how we can potentially circumvent some of the problems that are coming up. Before I get started, though, I wanted to start off with a case. Since I'm a clinician, this is something that we often are struggling with, are these tough cases. And so this is a woman that I saw last week, and I think really illustrates some of the quandaries that we're put in. So let me tell you about this woman. She's a 43-year-old Asian woman who has chronic hepatitis C. And just so you know, actually about 10% of all our patients in the Harborview Hep Liver Clinic are Asian. A lot of them are from Vietnam, so kind of a little mini pandemic there. And she has genotype 1. She has a viral load of 2 million, which is considered to be on the high end. She has a little bit of elevation in her liver enzymes, the ALT is 53, but otherwise has good synthetic function. Her INR is normal, her albumin is normal. And so she appropriately is referred for a liver biopsy, which is an outpatient procedure that we do, and we get a small piece of the liver. And she has moderate inflammation, grade 2, and also moderate amount of fibrosis, stage 2. And just so you know, we score it from 0, which is no fibrosis, to 4, which is cirrhosis. So she's, depending on whether you're looking at the glass is half empty or half full, she's halfway to cirrhosis or halfway to a normal liver. But usually that stage 2 treatment is optional. So she's otherwise pretty healthy. She just has some low-grade hypertension. And so she's sitting in front of me and she wants to know, Doc, what should I do? And so I'm going to come back to this case at the end of the talk, and I'm going to ask you all to vote, giving you a little bit of information, and see what you would do. So keep this in mind as we're going through this. So just giving you an idea where we're going today with the talk, we're going to first review the epidemiology, some of the stuff that Dr. Alter had gone over in the natural history. Then we'll talk about the current therapy, which is with pegylated interferon ribavirin, and talk about the efficacy, side effects, how it works, and then the importance of kinetics. This is an area of research interest for me. And then finish up with future therapy. So as Dr. Alter talked about almost a month ago, hepatitis C is quite common in Americans. Almost about 2% of Americans are chronically infected. This was based on an NHANES study. So what the CDC did is they basically went in these little vans and dispersed to the 4 corners of the United States. And it was originally was a health and nutrition survey. So that's what it stands for, National Health and Nutrition Survey. And it basically evolved over the years, and they wanted to look at some other issues, including herpes and hepatitis C. And so that's how they got this estimate of around 4 million are antibody positive and around 3 million are chronically infected. Well, one really important caveat is they didn't go to prisons, and they didn't go to Indian reservations, and they didn't go to enroll patients who are homeless. And so I work in the prisons, and 30% of inmates in Washington State are hepatitis C antibody positive. So that's a huge population that we're missing. So we think it's probably even twice as high as that. 7 million people have hepatitis C. Tends to be an infection of baby boomers, and it affects African Americans and Hispanics more often than Caucasians and Asians. So in terms of how people get hepatitis C, this is primarily a blood-to-blood exposure. At Harborview, I'd say about 80% of our patients that report at least some kind of injection drug use. And I'm surprised at how many times people say they only used once or twice. I was just experimenting when they were young, and then they never did it again. So I always ask, did you ever use even just once or twice? And the other follow-up is I ask, did you share paraphernalia or share works? Because a lot of times people say, well, I never share needles, but they sometimes will share other paraphernalia, and people can definitely get hep C from sharing other paraphernalia besides the needles. So blood transfusions, especially before 1992 when we had a screening assay, that also goes for organ transplants before 92, before we could screen for the disease. Multiple sex partners, I think Dr. Alter went over that a little bit. It tends to be those who have more than 20 lifetime sex partners. And then she really spotlighted this issue of iatrogenic hepatitis C. So I'm sure a lot of you heard about the outbreak in Las Vegas where an unscrupulous gastroenterologist was reusing syringes, and there are at least 8 cases that occurred through that reuse. But also in the newspapers lately there's been an outbreak in the VA. A year ago there was an outbreak by an anesthesiologist in New York City. So every year we hear about kind of these iatrogenic cases. And then one thing that as a physicians that I often get consulted on are people who either have needle sticks, or they're surgeons and there's some kind of a sharp bone or something like that. So there's a fair amount of occupational exposure as well. Hemodialysis patients, there's a large amount of blood being transfused. So this is one of those under-recognized, but certainly is going on, transmission routes. Snorting cocaine, just because patients have a lot of bloody noses, and they can share straws with that. And then piercing, tattooing, and scarification, especially this in Native American cultures, as we've seen some of this practice with the Sundance ritual, where there actually is ritual cutting. We see it sometimes in other cultures, but especially if they're not using some kind of process of sterilizing the knife, then that certainly can be transmission. I'd say there's about 10% of people who, I go through this whole list with them and they still don't have a known route of transmission. And really the only reason why it's important is I want to get an idea of how long they've had hepatitis C, and also to give them specific guidance. That's how we can prevent this from being transmitted to other patients. So this is probably one of the most important slides that I'll go through today. And I'll actually draw this out for my patients on their first visit. And the point of the slide is that hepatitis C is a slow process. So the time from infection to the time that you're going to have any of these adverse outcomes is usually about 20 to 30 years. And if you took 100 patients, actually 15%, maybe as high as 20, 25% of people can fight it off. And that's one of the areas that I know Mike Gale and others are trying to figure out, why do some people clear and the vast majority of people not clear? If you take those 85%, 1 in 5 or 20% are going to get cirrhosis. And that's really when bad things happen, okay? Once you get cirrhosis, you have about a 6% chance of getting end-stage liver disease, where the belly gets really swollen, people get really jaundiced, and about the only thing you really can do is either transplant them or they will die. And then the other thing that Dr. Lemon had spotlighted was this issue of liver cancer. So once you have cirrhosis, you have about a 4% chance per year of developing liver cancer. And I don't know if he mentioned this, but hepatocellular carcinoma is the fastest growing cancer in the United States. It's doubled in the last 10 years. And it's a particularly really aggressive cancer. I've seen people be diagnosed and dead within 3 months. And so we really want to prevent that. So what I'm trying to do with treatment is trying to intervene right here before cirrhosis develops. Now there are certain things that tend to add fuel to the fire and actually might make the natural history a little bit faster. So instead of 20 years, maybe 10 years. One of the most important things is HIV co-infection. So I'm an ID doctor. I saw patients with HIV, and liver disease is now the second leading cause of death in patients with HIV. We're doing a great job controlling their AIDS and HIV, but they're now dying of their liver disease. So that's becoming a really important issue. And of course, alcohol. So that combination of alcohol plus Hep C is a particularly bad combination. I tell my patients not like 1 + 1 = 2 in terms of the hit to your liver. It's like 1 + 1 = 4. So if any of you are medical students or in the medical field, that's probably one of the most important messages to patients with Hep C is really try to stop that alcohol. So we've come a long way with treatment for hepatitis C. This just shows the history of it. Starting in the late 80s and early 90s, we started using interferon for hepatitis C, and that was with just standard interferon for 6 months. I think one of the first people actually was Dr. Lau and Dr. Hufnagel at NIH. And Dr. Lau biopsied these patients after they had been successfully treated. And these people who had cleared the virus, their liver disease could actually get better. So if you had like stage 3, stage 4 scarring, you could actually have much better liver disease after you get rid of the Hep C virus. And that's what's unique about the liver, is it has this ability to heal itself. No other internal organ can actually heal itself. So that's why this is important. Then we started using standard interferon for 12 months. And then a real big jump was when we added ribavirin, which is a nucleoside analog, a pill. And if you use it by itself, it doesn't work. But somehow, if you add it to interferon, it was kind of like a turbo booster and really increased the response rates. And then the next advance was the use of pegylated interferon, which is, that's the PEG there. And so now where we are with treatment is pegylated interferon ribavirin from anywhere from 6 to 12 months. And your cure rate is a little bit over 50%, 50 to 55%. So as you can see, we've come a long ways, but there's still about half of our patients who we treat that we can't cure. So we still have a long ways to go. Now I wanted to talk about what this PEG is, this pegylation. And what it stands for is polyethylene glycol. So that's just abbreviated PEG. And you can see a picture of it in the upper right here. And what it does is it increases the hydrodynamic size of the compound. So you basically take the PEG, you put it on top of the interferon, and it allows it to have a much longer half-life. It's kind of like a sustained release form of the interferon. So practically what the body is seeing is a nice smooth level of it rather than these ups and downs. And in between those ups and downs, the virus is able to kind of rebound. Part of the way that it works is that there's delayed renal clearance. There are two products on the market that are pegylated interferon. The first one is actually PEG-Intron, which is made by Shearing. And it has a smaller PEG compound. It's only a 12 kilodalton PEG, whereas Pegasus, which is the Roche product, has a 40 kilodalton. The reason why that's important is actually the half-life of PEG-Intron. Even though it's packaged as 7 days, practically speaking, you start seeing waning levels and rebound of the virus after 3 or 4 days. So the upshot of that is understanding the pharmacodynamics and kinetics is I would advise people to use probably twice a week of the PEG-Intron rather than once a week. And just a little bit a note about the pegylation product. It was developed by Enzyme Pharmaceuticals, and one of their first applications was replacing adenosine deaminase for immune deficiencies. So like the boy in the bubble, this has been used to allow these children to have more of an immune system. Probably one of the things you've probably seen on TV is Neulasta, which is just a pegylated GCSF, so boosting the white blood cell response in patients who are on chemotherapy. And then also doxorubicin has been pegylated. That's a chemotherapeutic agent. And these are just two pictures of the PEG-Intron and Pegasus product. They're both injections, so that our patients have to inject it just underneath the skin like an insulin shot. So if you came to my clinic, you might see some people like this sitting in my waiting room. And this just speaks to how difficult the therapy is. You notice this guy's got a little bit of a rash. He's a little bit irritable. And those are some of the most common side effects. It's not just the irritability that we worry about, but interferon lowers the serotonin levels in patients so that people can actually get quite depressed to the point where we've seen patients who have killed themselves. I never personally have, but there's certainly been reports of that. So a lot of our patients come in with pre-existing depression. In fact, we've been doing a study in our clinic, and we surveyed 80 patients who are former injection drug users, and 1 in 4 had actually tried to kill themselves at some point in their life. 50% met criteria for depression, and these are people who have presumably been screened by their primary care doctors. So there's a lot of pre-existing mental health conditions. The other thing is this is kind of like chemotherapy. So people get nausea and vomiting. They have cytopenias. We've got to watch their white blood cell count, red blood cell count, and platelets. And so I really pitch this to my patients as this is low-grade chemotherapy. The only difference is your hair won't fall out. And it has this kind of kicker of depression. And so it kind of puts it in perspective. one thing that's interesting about interferon is we actually do use it for certain cancers like kidney cancer and for melanoma. So it is actually a chemotherapeutic agent as well. We do see some hair thinning, never see actually hair loss. And the other thing I wanted to highlight is how expensive this medicine is. It's anywhere from $25,000 to $40,000. So this is not a cheap medicine. Fortunately, there's some very generous programs from the drug companies that a lot of our patients get it for free. So with that in mind, we really want to be using this medicine in people who truly need it. And so a lot of times I'm asking myself, well, what's their chance of responding to treatment? And this is where this information comes in mind. The most important thing is genotype. It's like the old adage, what are the 3 most important things in real estate? Location, location, location. For Hep C treatment, it's genotype, genotype, genotype. And so practically speaking, I see 3 genotypes most frequently, 1, 2, and 3. 1 is the most difficult to treat, probably about a 40–45% chance with a whole year of treatment. The 2s and 3s are kind of like the low-hanging fruit, and their cure rates are around 70–80% with just 6 months of treatment. So I tell my patients, if you cross our fingers that you're an easy-to-treat genotype. The next thing that I consider is a viral load, and I kind of use 1 million as the cutoff. Anything over 1 million I consider high, below it is considered low. And that makes about a 10% difference. But there are some other things. Age, if they have cirrhosis, often they see more cytopenias, so it's hard to treat them. Race is increasingly identified as a really important predictor. For whatever reason, African Americans have a much slower progression of their disease, but they're much more difficult to treat. So if you took a white patient with genotype 1 and a black patient, the white patient responds about 50% of the time, the black patient about 20–25% of the time. And there's some ongoing NIH studies, the viral Hep C trial, that are trying to identify some of those immune markers for why that is. But it's not just African Americans. There was a recent study called the Latino trial that looked at Latinos, and their response rate is kind of halfway between whites and blacks. It's about 35%. So clearly race is playing a role in the response. Weight also, so anything over 85 kilos, your response rate goes down. And then our co-infected patients don't respond as well. And then the other thing I just wanted to highlight is the presence of steatosis. That just means there's fat on the liver. And if you recall from Steve Polyak's lecture, he talked about how the whole replication of hepatitis C is very dependent on lipid metabolism. And so that might be a clue to why it's harder to treat. Maybe these people who have more fat in the liver, there actually is a more rich milieu for the virus to replicate. And then finally, what's not on here is actually adherence. So are our patients taking the medicine? Just like with HIV, we've learned that some of our patients aren't taking all their medicine because of the side effects. And so we're really being quite aggressive with managing those side effects. Just to give you an idea of our success rate at Harborview, we get about 90% of our patients through therapy because we're quite experienced in managing a lot of these side effects. We have an in-house psychiatrist, we have a nutritionist, we have a fabulous pharmacist who does a lot of the side effect management. So we have kind of a great support network there. And I think it's a real model for how to do Hep C treatment. So next I wanted to talk about viral kinetics, and that describes the response to treatment. How quickly does the virus decline? And so this is a schematic where on the y-axis we have the log viral load, and then on the x-axis time. And you can see in that red line there is a person who really doesn't have much of a response. That's called a null response, or abbreviated NR. Next you see a blue line where the viral load's kind of coming down slowly. It comes down 2 logs by 12 weeks, and they eventually clear. But what I've shown here is that those people, if you stop at 48 weeks, those are the people who the virus will come back in most frequently, and that's called a slow response with relapse. Next, a green line there shows a little bit more rapid decline, and if you're negative by 12 weeks, your viral load is totally negative, that's called a complete early virologic response. And then finally, the best scenario is someone who's in that purple there who clears the virus by 4 weeks. Those are called rapid virologic responders. So the quicker you respond, the better you are likely to clear the virus. And I'm just going to go over that in this slide here. So looking at the first column in a patient who's negative at 4 weeks, negative at 12 weeks, this is their viral load, and negative at 24 weeks, their chance of being cured, that's what an SVR stands for, sustained virologic response, is 91%. That's regardless of their race, regardless of their genotype. This is genotype 1, but we've looked at this in 2s, 3s, and 4s. It doesn't depend, it doesn't matter if you're heavy, what race you are. If you have an RVR, you have a great chance of responding. So I check at 4 and 12 weeks to see how they're doing. And often the side effects kind of peak around 4 and 6 weeks. So it's great to have that news to say, hey, you've cleared the virus, or it seems to be working, and people can really get through that tough period. Next, if you have a person who is declining by 4 weeks but still has some virus, and they ultimately clear by 12 weeks, that's called a complete EVR, those people have a 60% chance of getting cured. If the people come down much more slowly and don't clear until they're 6 months in treatment, their cure rate drops down to 43%. And if you never actually clear the virus, your chance of cure is quite low. It's like 2%. So you can see there's a real big step down. And I can use this information to kind of customize their therapy and to be very aggressive with their therapy if needed. So next I wanted to talk about how interferon works. And before I do that, I just want to go over what is interferon. So interferon is this cytokine that your immune system makes. It has broad antiviral and immune modulatory activities. We all make interferon, okay? It's actually that compound that makes you have the aches and pains, the myalgias when you have the flu. So we all have this. And we're going to be talking practically about type 1 interferons today, and those are alpha, beta, gamma, and omega, okay? All of those have some hep C activity, but not all of them work in vivo. So gamma in particular, if you put it on a cell culture that's infected with hep C, it seems to work, but if you give it to a person who's infected with hep C, for some reason you can't get rid of it. So the PEG intron and Pegasus are both alpha, PEG interferon alpha. And you might hear something called consensus interferon or infragen. That's an interferon that they've kind of taken a little bit of the alpha, a little bit of the beta, and a little bit of the gamma, and kind of mixed it all together. It doesn't seem to have any more benefit than the PEG interferon, and it tends to have more of the psychiatric side effects, so we don't use it so much. So let me just walk you through the schematic. This is a schematic of an infected hepatocyte here. And what first happens is, let's see if I can, sorry, my pointer died on me, is you give large amounts of interferon alpha, it's recombinant interferon. It binds to the interferon receptors on the hepatocytes, and it activates the JAK-STAT pathway. And so you get dimerization. The next thing that happens is that activated STAT protein binds with interferon regulatory factor 9, or IRF9, and it translocates as a complex to the nucleus of the hepatocyte. And that complex then can activate interferon sensitizing genes. So this is actually an indirect activity. Interferon doesn't directly inhibit the hep C virus. It's kind of an indirect activity. Once those interferon sensitizing genes are activated, there's a whole cascade of events that occur, and that includes activating adenosine deaminase, which edits viral RNA, protein kinase R, which inactivates the viral protein translation, and then 2,5-oligoadenylate synthetase, which is OAS. That basically turns on a bunch of enzymes that chew up the viral RNA. So you can see there's a kind of a huge cascade of antiviral things that occur with interferon. So how does hep C circumvent some of this? Because I told you only 50% of the people respond. Well, we're trying to figure that out. and then we've got a little bit of a clue. One way is that the core protein of hep C can actually gum up the works of the JAK-STAT pathway. The next thing can happen is NS5 can block protein kinase R. There's actually some work that Mike Gill had done, and then Steve Polyak has shown that NS5 protein of hep C activates IL-8 and kind of turns off the antiviral state. The next thing is the E2 protein can also inactivate PKR. So these are just some of the mechanisms that hep C has developed. And what we don't know is if patients who respond have fewer interferon receptors. We don't know if there's something in this pathway, or even some of these downstream effects with ADA and up in this area. So there's still a lot of research that needs to be done to figure out how this is circumventing interferon. So next I want to talk about ribavirin. That's the other drug that we use for hepatitis C. And I just want to give you a little bit of a history of ribavirin. We've actually had ribavirin for almost 40 years now. It was developed by some medicinal chemist at ICN, which later became Valiant Pharmaceuticals. And they were really interested in purine analogs. They were interested mainly in them for their chemotherapeutic activity. And they were the ones that developed allopurinol, which is a drug we give for gout. And they came up with this compound ribavirin, and they wanted to see if it would work against influenza. Kind of a timely topic now as we're talking about swine flu and whatnot. But they are coming off the 1967, I think it was Hong Kong flu pandemic, and so trying to come up with some antivirals for flu. It didn't work for flu, bottom line. But they had a little bit of activity against RSV, which is respiratory syncytial virus. It's a virus that is really quite deadly for preemies, so for kids, and so it's given as an aerosolized form. But it's extremely expensive and has a very limited market. So the FDA licensed it in 1980, and it really didn't make much money for Valiant, and they actually ended up going out of business. And I think what's ironic is that by the time that we showed that it worked for hepatitis C, their patent was expiring. So in the 1990s, it was generic by the time that we got it into for patients with hep C. One other kind of interesting side note is that ribavirin's been used for some of the hemorrhagic fevers, so like Lassa fever. Those are all RNA viruses. So as I mentioned before, it looks like ribavirin is kind of an immune booster, and this is one of the first studies that showed that. There are 3 lines here. The first line are patients who got a placebo, and their viral load basically didn't do anything. The next group are patients who got standard interferon, and that kind of lime green. And you can see that they had a rapid decline in the first couple of days, and then it kind of came back to a steady state, about a 0.5 log lower than the baseline. The group that got the ribavirin kind of had a persistence of that antiviral effect. And so that's why I kind of call it an immune booster. There are clinical studies that then show that one of the main roles of ribavirin is preventing relapse. So this is a study in which all patients got peg interferon ribavirin for the first 24 weeks, and then at 24 weeks, half of folks stopped, and the other half kept on going. The green were the folks who kept on going. The red were the groups that stopped. And what you can see is that pretty quickly by 6 or 12 weeks after stopping the ribavirin, you had much more relapse. So that by the end of treatment, the relapse rate was, almost 50% in those folks who didn't get the last 6 months of ribavirin versus only about 25%. And those were all statistically significant. So you got to use ribavirin if you want to prevent relapse in our patients. So one of the big questions in hep C therapy is how the heck does ribavirin work? And I think there's more hypotheses than real solid answers. But these are some of the theories out there. One theory is that ribavirin can directly inhibit the RNA-dependent RNA polymerase, kind of like a chain terminator in the way like AZT works for HIV. One other hypothesis has it that it can deplete the intracellular GDP pools, so basically driving down the raw materials for replication. And then a mathematical modeling paper by Dixit was the first to hypothesize that there's actually that ribavirin is a mutagen. It basically causes an error catastrophe in the whole replication process. And then finally, there's some others that think that there's a kind of a favoring of the Th1 immune response over Th2. And I'll just show you a schematic of some of those mechanisms. So up here on the top, folks who take ribavirin, they might have more of a Th1 response. Other people who, there might be some kind of blocking of the IMPDH, and so less of the GTP. Some inhibition of the key polymerase, and then maybe just mutagenesis. So I'm going to stop right there, and before we go on to the future therapy, see if there's any questions about our current therapy. In the back, Matt?
Is there any idea how the Th1, Th2 system works?
There is, and beyond my knowledge base, yeah, I don't know much of it, but I think the people are trying to work on that. Yeah. Any other questions? Yeah. It is, and but one of the problems is it also it has a little bit of activity against the host, and so that one of the side effects of ribavirin is anemia. In fact, you can actually see what's called a hemolytic anemia, and we actually had a patient in our clinic who was really dramatically showed that. Started out with a hematocrit of around 40, 45, and within 2 weeks had gone down to 30. So basically, his red blood cells went down a third in just 2 weeks, and he was really feeling it. He was very, very fatigued, was having chest pain, and so that's because of it. He was having toxicity to his red blood cell precursors. So there have been some attempts to create a ribavirin that's less toxic to the host and more specific to the virus, and those have not, to this point, not been all that successful. There's a drug called teravirin doesn't seem to be working. Okay, question here?
So in terms of interferon therapy, long-term effects of interferon, at least what we know in mice,
Mm-hmm.
can alter the adaptive immune response. Do we see anything like that?
No, that's a great question. So, I mean, his question was whether there are any long-term effects of interferon. And I haven't seen it in any of those patients because I followed them at least 6 months after, and I haven't seen any kind of opportunistic infections or any compromise in their immune systems. And these people have been followed now for 5, 10 years, and it seems to be once you get it out of the system, they do pretty well. About the only permanent side effect I would see is sometimes people can get thyroid disease. They have some occult autoimmune thyroid disease, and sometimes we can really turn that on. So they need to take thyroid replacement for the rest of their life. That's about the only permanent thing I've seen. Yeah, question? Mm-hmm.
Is there a point where you're seeing non-responsiveness basically suggests that they quit therapy?
Yeah. So he's asking, is there kind of a fish or cut bait time? And that's 12 weeks. Yeah. So if you haven't come down by 2 log, that's called the stopping rules. And so if they haven't come down by 2 logs by 12 weeks, I say it's not going to work, and I save them 9 months of torture. And that's been fairly well worked out. That occurs about 20% of the time, and there's no predicting that. It cuts across race or body weight. I think it's really something about their immune system. Okay, so I'm going to talk now about future therapies, and I think this is a really exciting time to be in Hep C therapy. In the last 3-4 years, we developed this a culture system for replicating Hep C, and that's really advanced a lot of the fields in the basic studies. But one of the big advances for therapeutics has been the availability of these small molecule inhibitors. Sometimes you'll hear us say STAT-C. That's just an abbreviation for specifically targeted antiviral therapy for Hep C. And these are analogous to what we use for HIV, the HART therapy. And the good news is that they're coming soon. No one has a crystal ball, but I'm telling my patients probably 2011. They're very potent. The downside is that there's incredibly rapid antiviral resistance if you use it by itself. So the good news is it looks like they're more effective, but we're still going to need to use the interferon ribavirin. And I have to say that the interferon really is the rate-limiting step. So I treat about 1 in 3 of my patients because of my concern about the interferon toxicity. Whether that will change with these newer therapies, I don't know. No drug has a perfect side effect profile, and that's true of some of these newer drugs. I'm going to talk a little bit about telaprevir since we're one of the sites about telaprevir, but every drug has a side effect, so we're just going to have to learn how to deal with those. So before I jump into that, I wanted to remind you some really key features of the Hep C life cycle. There's a variety of receptors that Hep C uses, CD81, SRB1, claudin. So it's not like HIV where there's just a CD4 receptor. There's a variety of receptors, and that might make things a little bit more difficult. And the other thing that I really wanted to highlight was what Steve said, that the Hep C life cycle is really intimately tied to lipid metabolism. And that might be a potential Achilles heel in Hep C. So that's something we can exploit and potentially target. The other thing about Hep C is it's incredibly prolific. So a person who has chronic Hep C cranks out 1 trillion new virions. That's 10 to the 12th new virions a day. And to give you just a perspective, HIV cranks out 10 to the 10th. So actually 2 logs lower per day. And you got this RNA-dependent RNA polymerase that makes a lot of mistakes. So if you're cranking out 1 trillion and you got a polymerase that makes a lot of mistakes, that virus is going to have a way to elude your immune system, and it's going to have a way to elude some of these new drugs. So I think the strategy going forward is kind of have to do the left jab, right hook, and maybe a karate chop kick or something like that. And the other thing that Steve talked about are this concept of quasi-species. Well, those are the highly related yet genetically distinct viruses, and that was the picture he showed of his 2 daughters. And so what we've seen is that the virus can exist in these really heterogeneous mix of virions that can potentially adapt to the drugs that we're giving them. So just to remind you, the drug development process is a long process. What happens often is there's a drug screening that goes on in the laboratories of many of these pharmas. And they will screen thousands and thousands of potential compounds. And then a handful of them will actually get into animal studies. And part of the problem is we don't have a real good small animal model. We do have chimps, but which are extremely expensive to maintain and to test. And so that's been one of the big difficulties, is not having like a rat model or something like that. Once you get into human studies, that's called phase 1. And really what we're trying to do in phase 1 is make sure this is safe, because it's first in man. And you want to make sure you're giving the right dosage. And the next when you get into phase 2, you're looking for effectiveness, keeping real good track of the side effects. And then when you get to phase 3, you're talking thousands of patients. And now what you're doing is you're comparing it to the gold standard. And you're just trying to show that it's somehow either having fewer side effects or actually it's got a better response. And just to give you an idea, these studies they were progressively more and more expensive. So by the time you get to phase 3, you're talking well over $100 million just for one of those phase 3 trials. So very expensive. And as Steve pointed out, very few of these drugs actually get approved for the FDA. So it's a kind of a gamble by the drug company to get them there. So what I've heard is that for 20 drugs that make it phase 1, only 1 will get approved. So it's kind of a big deal. So this is all of the drugs that last time I checked are in drug development. Looks like 2025. And in addition, there's probably another 10 or 15 that have already been killed, or they had too much toxicity, or they didn't work. What I want to highlight are the 2 drugs here that are in phase 3, VX-950, which is Vertex 950 or telaprevir, And then the shearing drug, SCH5030-304, is also known as boceprevir. You probably hear about those, read about those in the press. I think most people are pretty confident that both those drugs, or at least one of them, will get approved in the next 12 to 18 months. They're both fast-tracked by the FDA. So I'm going to present some of the data on the Vertex drug today. So before I do that, though, I wanted to just remind people the HCV life cycle and just remind you that all the various parts of the life cycle are potential targets. So from receptor binding to the fusion and encoding, translation, RNA replication, those are all potential targets. But really what seems to be the easiest and most effective right now is that area right there, translation and polyprotein processing. And so this is what the NS3 protease looks like. This is what both the shearing and the Vertex drugs are going to be targeting. And the reason why I point this out is that Mike probably talked about how NS3 and NS4, the protease can knock out IRF3, the kind of the signaling pathway. So there's a biologic basis for why this new drug, the telaprevir and boceprevir, might actually be hitting an Achilles heel of Hep C, is to knock out this area right here. So these are all the drugs that are protease inhibitors that are in clinical trials. I mentioned telaprevir and boceprevir. Tibotec has one. Intermune is now partnering with Roche for their protease inhibitor. Merck will be rolling out a phase 2 trial with them this summer. And Boehringer Ingelheim actually had the first drug on market, which had a cardiac toxicity, and then now they're coming out with a newer agent. So a lot of drugs in that category are coming down the pipeline. So I wanted to show some of the early data with telaprevir and give you an idea of how potent it is. So if you gave patients just those Pegasus, you can see their viral load drops about a log. If you give just the Vertex 950 drug, it will drop about 4 logs on its own, but when you add the interferon to it, you get a synergistic activity. So, 5-6 log drop by just by 2 weeks, so pretty quick. So what I mentioned this problem of resistance, and so this was a study that was done by Tara Kiefer and presented at AASLD a couple of years ago, and they did sequential resistance and sequencing, and they highlighted the really bad mutations, which are kind of the hot colors here, red and orange, and then the wild type is in purple. So in the next figure, look for the red and orange. Those are the bad ones. So if you gave a patient just monotherapy telaprevir, their viral load will drop on average about 4 logs, but then it kind of plateaus. And what it's plateauing with is really resistant virus. See by 14 days, the strains that are circulating there are no longer wild type. Those are the ones that have single, and in some cases, double mutations, and would be very highly resistant. And probably you'd see a viral load go back up to baseline if you kept them going. Here's the good news, though. If you give interferon, you can rescue that, and you drive the viral load down to undetectable. So the next experiment is, well, what if we give them all 3 drugs up front? And what it showed is you don't see any of those highly resistant mutations, and you can drive the viral load down very, very quickly. So that's kind of the concept going forward, is you hit them hard with 3 drugs, and then you can back off to maybe a consolidation of PEG and ribavirin. So I wanted to go over the PROVE-2 study. This was actually published in the New England Journal about a month ago. If you want to read it for yourself, there's a European study, and there also was an American study. I'm going to present the European data just because it looks a little bit better. And there are 4 arms in the study. The first arm was standard of care, so PEG and ribavirin for genotype 1 for a whole year. The next arm was giving triple therapy for 12 weeks, and then continuing with just the standard of care for another 12 weeks. And then the other arm was to try to treat these people with just 12 weeks, the group C, and see if you can stop there. And then this last arm was trying to drop ribavirin. okay? And what it shows is that these are the kinetics of those patients. The folks who are standard of care are in gray, and their cure rate was 46%. And the folks who got 12 weeks of triple followed by 12 weeks of PEG and ribavirin, 70% cure rate. So we're talking about that's a 50% improvement. And then it's half the treatment time. So it's kind of like we're shortening the treatment time by half, and we're increasing the response rate by 50%. So that's a really encouraging study. The major side effects in this trial were rash and GI side effects. So kind of upset stomach and diarrhea, things like that. But I think their discontinuation rate wasn't dramatically different. So next, I wanted to talk about the folks who are treatment experienced. So, my clinic, I've got about 30% of my patients who I've already treated, and they didn't respond. Either they relapsed or they were null responders, and I haven't had anything to offer them for 5 years now. And so this data really gives me a lot of encouragement. This was a study of patients who were prior non-responders to PEG interferon ribavirin, and they got the standard of care in arm A here. The next group got 24 weeks of triples followed by another 24 weeks of consolidation. This group got 24 weeks of triples, and this group got 12 weeks of triples plus 12 weeks of consolidation. And I'm going to show you data from these two groups right here. And here's the overall cure rate, 50%. So 50% of the people who previously had not responded to interferon with just the one telaprevir were able to get cured. So, and it's a little bit surprising because you would think that we're basically giving these people monotherapy because they were resistant to interferon and ribavirin before. So I think that this has created quite a bit of buzz at the last liver meeting. And if you look at certain subgroups, if you look at these non-responders, these are people who, their kinetics were totally flat. 41% had a cure, and people who relapse, it's as high as 73%. And the good news is this trend has held across racial groups. So our African American patients, their response has bumped up. Still not the same as whites, but the Hispanic rates are approaching cure rates in whites. So this is very encouraging for a lot of our patients who haven't responded in the past. So I think the really intriguing question is, can we get away from interferon? Because as I said it before, interferon is really the big hurdle. It's the rate-limiting step. And so the good news is that two companies are developing protease and polymerase inhibitors at the same time. Roche is now in phase 1. They gave 10 patients in New Zealand this combined protease and polymerase inhibitor. It looks safe, and now they're moving on to phase 2 and trying to get the efficacy data. And then Merck just merged with Schering, and they both have a protease and polymerase inhibitor. So you'll start seeing some of those data coming out in the next couple of years. So this is kind of the current situation where we have PEG interferon ribavirin. We've got about a 50% cure rate. In 5 years, is it possible that we're going to be seeing a 70% cure rate? Sure. I think based on the telaprevir, and I didn't go over the boceprevir, but it's approximately the same, maybe a little bit less efficacious. Still got to use the PEG and ribavirin. But I think what's intriguing is, in 10 years, are we going to be using a polymerase and a protease inhibitor by just two therapy, or maybe we use a reduced dose of the interferon, we use a shorter course of the interferon, and are we going to get cure rates that are well over 70%? That's my hope. So there's a lot of questions still out there, and I still don't think we have a good handle as why interferon doesn't work in some of our patients. And I can tell you, I have patients who, you line them up. One guy here who's 40 years old, he's white, genotype 1, viral load 2 million, stage 3. Basically have the same guy right next to him, and I've followed their kinetics, and they're just totally different. One guy's a null responder, the other guy has an RVR and is cured. So they look like they could be brothers, but they're very different. So there's got to be something about their immune system, and we really need to work on elucidating that. The other question I didn't really go over is why interferon is so much more effective in acute Hep C. So if patients get Hep C and they're still viremic by 3 months, I'll often treat them. And I have a great response rate in those people, 80, 90%. Those are genotype 1s. So there's something about the immune system that's still activated, and giving interferon tends to be very effective in that situation. The next question is, do you even need interferon with some of these newer potent compounds? And if not, then how many antivirals do you need? Do you need 2? In HIV, we've learned you need 3. And then how long would you need to treat these people? And then the last question we raised earlier is lipid metabolism a potential target? And I just for those who are interested, there's an article that was in American Journal of Gastroenterology where they gave fluvastatin to patients with Hep C, and it had a modest effect. I think they had this is just fluvastatin by itself. There's about a 1 log reduction. It was tend to be temporary. And then Mike Gale actually was a co-author in this paper in 2003 with Joe Goldstein and the fathers of the LDL receptor and PNAS that show that it seems to inhibit Hep C through granulation. So there's lots of avenues to target, lots of questions still out there, and I encourage you to have an open mind, and if you're interested in this, to talk to us about some work with us. So I want to finish up with a case. So now that you guys are all semi-experts on hepatitis C treatment, this is the woman I saw last week. She's 43. She's got stage 2, grade 1, and the question is, do we treat now with PEG interferon ribavirin, or should we wait? So how many people would treat this person? Anyone treat her right now? Okay, 1, 2, well, maybe about 7. Okay, so how many people would wait for these newer antivirals? Yeah, so it's about 50-50, and that's what I do, to be honest with you, is I present this data to our patients, and I really try to give them the data, make sure they're informed as possible, and you'll be surprised. Some people say, this is a good time in my life. I want to do this now. I don't want to have that, the whole adage, 1 bird in the hand is worth 2 in the bush. Some people want to get it done now. Whereas other people said, I want this newer therapy. I can wait a year or 2. So in this case, she actually elected to wait, and I basically support either course. So I just wanted to finish up by saying thanks to my mentor, Larry Corey, and Cha Wong, who was really helpful in getting me in this track of looking at viral kinetics. Dave Gretsch is a collaborator, and my wonderful study creators, Erica Koppel and Erica Sedig, Wanjong Q helps out in the lab. And Steve Polyak and Jean-Michel Polatsky were very nice in sharing some of their slides. And of course, our patients, and my work is sponsored by the NIH and NCR. So I'd be happy to answer any other questions at this time.